Kia ora tatou, everybody. Bruce Arrell's my name, and I'm the director of the Goodfellow unit, and I'll be hosting tonight. So we've got a great lineup of speakers tonight. We're going to be covering a whole bunch of things: COVID, monkeypox, influenza, polio, meningococcal disease, and a little bit of stuff on invasive strep. So our first speaker tonight is Dr. Tim Cutfield, who's an ID physician at Middlemore Hospital. Over to you, Tim.
Been asked to give a little bit of an update on COVID therapeutics, looking forward into the year. And I guess the first thing to say is that COVID looks quite different now, we all know this, than it did a year ago, or certainly 2.5 years ago, 3 years ago when this all started. We're seeing a lot of COVID still, kicking around in the community, which is the very familiar camel-shaped yellow curve on the left-hand side of the screen there, which are cases in New Zealand per day. There's still quite a lot of those, and it's a similar story throughout the world. But the case fatality ratio, you're acknowledging lots of different things that might influence the absolute numbers. You can see steady stepwise reductions in the chance of dying of COVID-19. And that's just New Zealand's little step ladder down towards very, very low rates of mortality now associated with an infection. So I guess there's lots of things that could contribute to that. And overall healthcare, the increased vaccination, hybrid immunity, care at the level of provision of treatment in primary care, and then for the few people who do get sick, we've got great treatment available in hospital. So just focusing on the treatments that we do have in the community, and I guess if there's one thing that I want you to take away from that, this is the molnupiravir message. Many of you will already be aware that molnupiravir, I spoke about last year, was probably the one where there was a bit of doubt about how well this agent was going to work. Everyone wanted it to, because no side effects effectively, no interactions, but some dodgy data in the registration trials, and then maybe the effect is there, but very, very small compared to some of the other treatments. This trial, Panoramic, was published just before Christmas, although preprints beforehand, to more properly evaluate the question of efficacy of molnupiravir in a contemporary environment. And so it's a UK-based trial, really cool, open label, but community-based randomization that was done through the internet and looking at people who were eligible on the basis of having some risk factors, being over 50 or some comorbidity. So slightly more permissive than our current prescribing requirements in New Zealand. But they were looking at hard clinical outpoints that were, did you end up in hospital because of COVID? Did you die because of COVID? And did molnupiravir influence that outcome? And the bottom line is no. Molnupiravir did nothing to influence your chance of hospitalization or death from COVID-19. And that was despite people getting their molnupiravir really, really quickly, and at the point where viral replication is at its peak, where you might expect an antiviral to have some efficacy. And you might have thought, well, gosh, what about some small subgroups within this? The answer was no. No subgroup was found to have efficacy from molnupiravir. And it was interesting, and the authors made some point about this, that people who got molnupiravir compared to not getting molnupiravir rather than a placebo felt better quicker. But obviously that's subjective to a significant placebo effect of receiving a golden packet of pills in the post when you're feeling slightly miserable at home. So quite some uncertainty about whether or not that general feeling does anything. But I guess the bottom line is the reason that these pills we put so much effort into giving to people in the community was to try and keep people out of hospital, stop them dying with severe disease. And molnupiravir does not do that in a contemporary environment where the prevailing variant is Omicron, causing less severe disease, and people are vaccinated or have had prior COVID in the past, or a combination of the both. So, and there are some caveats to this data. No study is perfect, but I think this is a practical and pragmatic look at how we now see COVID, and says molnupiravir really is not something that we should believe does anything for our patients. Real world studies, this is the new term that's bandied around in any retrospective observational study that's large enough, but this is a retrospective observational study. Depending on where you find these studies, people may believe some of the messages that are sent, including things like, well, perhaps it really does work for older people. Maybe it's really important if you give it early and for people with lots of risk factors. But I think we should have learned by now from the stories, the other agents that have been tried in COVID therapeutics, ivermectin, hydroxychloroquine, zithromycin, that you can't rely on the message sent by observational data, particularly if it's retrospective. There are too many confounders and complexities in the world, particularly with the COVID care at the moment. So I think we should believe the high quality data, which says this does not cause benefit. And actually, I've included this graph from a recent large observational study from Israel that said that the overall effect was nothing when you looked at the total population, regardless of the subgroup slices. So I'm being slightly melodramatic at the title that molnupiravir is dead, but I think that's a reasonable take-home message from my talk tonight. What about Paxlovid? Well, we could talk quite a lot about that, but I don't really want to, because we don't have the same contemporary high-quality data for Paxlovid yet. Talk about a couple of studies that are going to look at that very shortly. These slides, thanks to Susan Morpeth, who talked about this at Middlemore with us very recently, essentially saying that what sort of modest quality data we do have in terms of, people trying to do their best to make a message out of retrospective analyses, very consistent findings of an ongoing reduction, both in risk of hospitalisation and death with Paxlovid prescribed in the way that we currently use it. Not to say that is data that's got all the same flaws that I just rubbished molnupiravir studies with, but in the absence of the studies that will answer that question, Paxlovid probably still is the one antiviral that we should be putting our effort into, and probably is still, even though the absolute risk of severe disease is reduced for people who had a really high risk beforehand, very elderly, the very comorbid, people who are immunocompromised, that relative risk reduction seems to be maintained. So still something that we should be putting some effort into prescribing for our high risk patients. There are some trials that are recruiting at the moment that hopefully will answer the question of how good Paxlovid is, if it has an effect still, and we probably won't have those answers until next year. The only other things to say about Paxlovid is, as you may have had some messaging, for select patients, there's some small studies that suggest that you probably can use this where the benefit outweighs the risk in people with advanced kidney disease and also pregnancy and breastfeeding. But because the data is not great, that would be really in select people you're really worried about and in discussion with secondary care, people who know the patients or can give some advice over the phone. And if anybody's screenshotting this is a link to a Ministry of Health Therapeutics tag paper that just summarizes the dosing for low kidney function, if you happen to have someone who you're using that for. What's kind of remarkable is that despite the antivirals being used widely throughout the world, there's very, very little evidence of antiviral resistance developing, which is both a good thing or slightly worrying if you're a cynical virologist. So this is some data looking at the new emerging variants, saying that they all still seem to be treated adequately in a lab by the antivirals. But that's not the case for the antibody treatments. So evolution has happened, antibody treatments have been out-evolved, and this is an example where you want to see nice S-shaped curves demonstrating your antibody at higher titers is neutralizing the virus, but the newer variants are the flat, colorful lines at the bottom of all of those charts, saying that none of the therapeutic antibodies that we have in the shelf do anything against contemporary Omicron variants. The reason to emphasize the importance of that is if we look at our current variant soup, where the pink was BA5, and you can see that's just reduced from November through to February down to 4%. And BA2 was the other one that might have been had neutralized by Evusheld. As of a couple of weeks ago, less than 5% of all Omicron variants might have been prevented by Evusheld. And so we definitely don't recommend using any Evusheld anymore. It's just going to be a waste of time and a sore jab in the bottom. But the other thing that's really important for your patients who have had Evusheld, if they're immunocompromised, is that they should no longer feel bulletproof. They no longer have effective serological protection against the contemporary variants. And so the previous advice that we would have given in terms of maximizing vaccination, mask wearing, avoiding crowds and things like that in the height of their immunosuppression is still sensible. But as a night, if you haven't already chucked it out, chuck it out. It was a very, very weak treatment to be considered at times when we were dealing with life-threatening variants in unvaccinated populations. The relative risk reduction now doesn't warrant it being considered anymore. So I would strongly recommend against any use of budesonide at this point. So therapeutics of 2022. The good news is the virus is very different. in terms of the illness that it's causing because of a variety of factors that we touched on very briefly. So we're in a much better place than we were a year, 2 years ago. Paxlovid is the one really therapeutic that we have in primary care that is anticipated to do anything for your patients. And the other ones we really couldn't recommend you putting any effort into prescribing for your patients unless you had some specialist who had a reason to believe that there was something special going on in that situation. And as a sort of a segue into Anthony's and the other vaccinology talks later, prevention is definitely better than cure still in 2023.
Thank you, Tim. Our next speaker is Dr. Anthony Jordan. He's an immunologist at Auckland City Hospital and is going to be talking to us about testing and vaccines. Over to you, Anthony.
So I'm going to come back to testing later, which I think we'll talk about at the end, but I'm just really wanting to do an update on the arrival of the bivalent COVID vaccine, just to sort of put into context something that's arrived in the country, I should say, and is being imminently rolled out at the end of the month, and will be the topic of a lot of discussions around the efficacy of this booster over the monovalent vaccine that we've had in the past. So just to make our lives more difficult, the end of the purple cap vaccine is coming. So that was our ancestral original strain COVID vaccine that we diluted, and people that have made it up will remember the turning mechanism. This is now a diluted vaccine, so you don't need to add diluent into it. The original ancestral strain, the Comirnaty 30 microgram, is still being used for a primary course. And I said to someone the other day, oh gosh, there mustn't be many people out there that are still having a dose 1, dose 2. And they reminded me that actually about 150 people are still getting their first or second dose across the country every week. And this is partly because the licensing at the moment for primary courses is still to use the original ancestral strain vaccine. That's still being looked at in terms of whether or not you can use the new updated bivalent vaccine like it's being discussed in the US at the moment. Again, sadly, a grey top for the bivalent COVID vaccine, which contains the original ancestral strain at a lower dose, only a 15 microgram compared to the 30, and then another 15 micrograms of the Omicron BA.4/5 strain. Again, this doesn't require dilution, and it's for a booster vaccine for those who are ages 16 and above. The plan is that there's a lot of promotional materials, and I see some of my colleagues here from IMAC on, and I'd just like to thank them for all the material that they've put out. There will be a lot of material being shared around making sure that we can reduce any errors, considering Pfizer and their wisdom have chosen to put grey caps on both of these vaccines to support people when they're vaccinating to prevent any errors of mixing up the original vaccine and the booster vaccine. And so we really want to remind people that for primary courses, it's still the 30 microgram original dose at the moment, and for boosters, it's the new grey cap booster, which is a split 15 microgram dose. There'll be a lot of webinars that some people have attended to learn about this new vaccine, and it's important just to understand that there's really good tools out there and promotional materials to sort of guide us through things like how long it can remain in the fridge for, and advice around transporting the vaccine when you're doing either in-home vaccination or vaccine events. So what can I tell you about the bivalent COVID vaccine? I've mentioned it's only 15 micrograms of the original strain and then 15 micrograms of the BA.4/5 strain. This is a vaccine that has a very similar safety profile and is comparable to the original strain vaccine. Remember, it's being used in smaller populations of people than we saw with the original strain vaccine. So safety monitoring continues on to make sure we see no uptick in some of those rarer side effects. It's been difficult for people because there was a lot of quickfire decisions made in late 2020, especially in the US, which means that we haven't been able to continue to compare, at least in the US and other jurisdictions, where they removed emergency legislation to continue to use the original monovalent vaccine in comparison to the bivalent vaccine. But again, it is something that we have, and I think for the booster vaccine is definitely something we should be embarking upon, getting our patients who are at risk of getting severe disease in the future. So the CDC have published data. They looked primarily at preventing symptomatic infection within 2 months of the booster. You know, they chose to do that, that's fine. We're more interested in protecting people against hospitalization and severe disease. However, in this comparison, when you compared it to the monovalent vaccine that had been given 2 to 3 months earlier, the bivalent vaccine at preventing symptomatic infection averaged across many age groups and comorbidities about 28 to 31%. If you extend that back to having the monovalent vaccine more than 8 months earlier, that increased a little bit to 43 to 56%. So this is something that's more effective, and this set of data that was submitted to the FDA as well as part of their approval than the monovalent vaccine. Very short time frame, only looked at 2 months. So we just need to remember that we still may see, as new variants are circulating, waning in that protection over time. And Tim's already produced the rates of different strains in New Zealand. So BA4 is no longer really circulating, BA5 is at 4%. So they're rapidly declining as part of our COVID strains that we see in New Zealand. We now have much more immune-evasive strains such as BQ1, BQ1.1. There is some data showing that these vaccines, when you look at neutralizing antibodies, are still effective against strains such as XBB. However, the degree to which neutralizing studies confer a solid clinical endpoint has been something that's eluded us ongoing for years now. So I just sort of caution against focusing on neutralizing antibody studies alone. I think for most of us, we're seeing, as Tim's put up on the slide, with hybrid immunity, with the original vaccination program and with people getting boosters, that most people are suffering only a mild disease. So we just have to be careful that we're not chasing just symptomatic infection alone and vaccinating for only that reason. But in our most high-risk people, those over 65, those that are multiply comorbid, the bivalent does reduce hospitalization in some studies. I think 73 to 84% has been touted for those that have no boosters. But when you look at compared to the monovalent, I suggest that some of those observational cohorts suggest it's maybe a lot lower than that. But it's still comparatively better than the monovalent vaccine based on the data we have to date. So the key message from me is we have a bivalent vaccine and we should use it in our most at-risk populations. From the 28th of February, we'll be asking people to remove their purple cap stock to prevent any errors, and you'll get your grey cap stock. And we're just really encouraging people to take care and caution to not mix up those two doses. And ultimately, our major problem still remains accessibility and distribution for vaccinations rather than focusing on incremental marginal benefits. And the vast majority of the population, if we're thinking about achieving equity and outcomes for all of our people here in Aotearoa. So I think what we'll see is over the sort of March period, a revision of who is eligible for boosters when we talk about the bivalent, who's most likely to benefit from a bivalent vaccination. Remembering this will coincide with our flu vaccination population. Our COVID booster can be given with the flu vaccination. So we really want to make sure that when people are coming in for interventions such as the flu vaccine, that we're checking to see that they're eligible, if they're eligible for a COVID vaccine, and give it at the same time. And hopefully I kept to time.
So our next speaker is Teena Mathew. Teena is a sexual health physician and as well an advanced trainee in infectious diseases. So she's going to talk to us about monkeypox.
My name is Teena. I'm a sexual health physician and also an advanced trainee, currently working in infectious disease and general medicine, currently working in Auckland City Hospital. So my main objectives would be to talk a little bit about the epidemiology of Mpox, the clinical features, diagnosis and management, very briefly, and vaccination. So Mpox or monkeypox is a zoonotic disease which was mainly endemic in parts of Africa, and is caused by an orthopox virus called the monkeypox virus, which is very closely related to the smallpox virus or the variola virus, which was eradicated in 1980. And since then, the most common orthopox virus infections have been monkeypox infections, mainly in the endemic areas. Now, outbreaks outside these endemic countries were quite rare before 2022. But in May 2022 onwards, there's been a multi-country outbreak of Mpox with no link to Central or West Africa. And this outbreak was mainly affecting, or is continuing to affect mainly men who are sex-ed men. The good news is that the numbers are falling globally after a peak in early August 2022. The World Health Organization declared it a public health emergency of international concern in July 2022, but it's decided to keep it as a public health emergency of international concern because there are still outbreaks going on in many parts of the world. So if you look at the global trend, and this is updated on the 19th of February 2023, there have been over 85,000 cases from 110 countries and 92 deaths. And this is, we have the peak in early August, and as you can see now, the numbers are really low, and they're mainly being reported in the region of the Americas. Now, if we look locally, we've had 41 confirmed cases of Mpox, and the last update was on the 25th of Jan, and I think since then there have been a couple more cases. 10 acquired the infection overseas, and 31 acquired the infection locally, and cases have been reported from the North and the South Island. And where sexual behavior was available, the majority reported we reported to be MSM, and 6 cases were admitted to hospital. Now, if you look at the clinical features, the important thing about the 2022 outbreak was that there were a lot of atypical features which are not previously reported. The incubation period is 5 to 21 days, an average of 8 days. Traditionally, it had a prodromal phase, but this particular outbreak, prodromal phase could actually be absent, and sometimes the prodromal phase starts after the rash. A typical monkeypox rash is also monomorphic, which means that all the rash look the same. So if a person has papule, then the whole body should be covered with just papules, with the centrifugal distribution, which means starts in the face and then goes to the rest of the body. However, during this outbreak, there were polymorphic rashes and rashes which were not centrifugal in distribution. And the number of skin lesions could be very low, with a few and mainly genital areas being affected. And some people only had 1 or 2 skin lesions, and there were also reports of asymptomatic infection and transmission as well. So transmission person to person is through close contact, including skin lesions, body fluids, respiratory droplets, and contaminated materials such as bedding. Now, this is a picture of the progression of the Mpox rash. You can see that a person could present at any stage, and each stage looks slightly different. This is on vulval skin. And again, you can see the progression of the rash. If you look at all the symptoms that Mpox can cause, any rash is the most common symptom. And fever is the second most common symptom. And then you can also see genital rash is up to 50%. The important thing is now this rash looks something like secondary syphilis, so not typical monkeypox pictures that you saw earlier. And this one could be anything like a viral exanthem, but this was a case of monkeypox. And this is a tonsillar ulceration, which again was a case of monkeypox. So it can mimic a lot of other things. So be aware of the differential diagnosis, and especially in New Zealand, because the numbers are really low, most cases are likely of rashes likely to be one of these rather than Mpox, but also to have Mpox in your differential diagnosis. In terms of diagnosis, the health pathways have been really updated, and so it's got quite detailed information. And the Ministry of Health website has regular updates on case definition. And currently testing is recommended only for those people who meet clinical and epidemiological criteria, and the health pathways clearly state what those criteria are. So basically, the epidemiological criteria is that if you've been exposed to a confirmed or probable case within the last 3 weeks, or you're a priority group for testing. So this means the MSM, or people who have multiple anonymous sexual partners, or history of travel to an endemic country. Now, previously, it was a bit tricky to test for Mpox. There were far too many restrictions. So you had to first discuss with the medical office of health, and then with the microbiologist before you could do a test. But that's been changed now. And also, if anyone was tested for Mpox, then they had to isolate until after the results were back. But this is all changed now. So you can test for Mpox if you meet the clinical and epidemiological criteria without speaking to the medical office of health or the med microbiologist. And the isolation requirements are need to be met for those people who meet the high-risk criteria, which is again quite detailed in the health pathway, so I won't repeat it here. So if you're in doubt if a person needs to isolate or not, you can speak to your local medical office of health. Management, just remember Mpox is a self-limiting illness. The vast majority will be fine, and all people, it just requires supportive management, and supportive management with specific attention to pain control, especially because that was the most common cause for hospitalization during this outbreak. And then hydration, especially for people who have oral lesions and have trouble swallowing, and skin care, because secondary infections can cause sepsis as well. And proctitis management is also an important part of management. Again, the health pathways gives detailed information about how to manage this. A person is considered non-infectious after the scab falls off, and currently the requirements are to isolate for 7 days, and the medical office of health decides when a person can come out of isolation, and that's usually like a 2-stage process. There's also recommendations again with regard to limiting contact with pets. Currently, if a case is diagnosed as Mpox, then the lab automatically will inform the medical office of health, and then they will do the contact tracing and testing and isolation of the contacts. Individuals are also recommended to use condoms for sexual contact for 8 to 12 weeks after, as well as there is shedding of the virus in genital fluids. There's also treatment available in New Zealand, which is Tecomerimat, or Tpox in short, which is quite easily tolerated with minimal side effects. The real efficacy of this is actually not known. The studies are being done, and so it'd be interesting to see what the real efficacy is. Currently, in terms of indication for treatment, which is also there in the health pathways, I'd like to divide them into 3 groups. One are the ones that definitely require treatment because they have severe disease and they require hospitalization, and those are the ones with hemorrhagic disease or large number of lesions or sepsis or encephalitis. The second group of individuals are people who have lesions in key anatomical sites, so eyes, pharyngeal regions causing dysphagia, or penile foreskin, or urethral lesions, or rectal lesions interfering with bowel movements. So these are key anatomical sites. If they get complicated, then can cause strictures. So treating them early might prevent that. And then the third group of individuals would be the people who are at risk of severe disease. So those are the severely immunocompromised individuals. And through COVID times, we know who these are, children who are under 10 years, pregnant individuals, and older adults, 60 years and older or 50 years and older for Maori and Pacific people. So complications, bacterial infection is the main cause of sepsis and death, or encephalitis is the other cause of death in Mpox. Others are abscesses or significant proctitis, rectal perforation, urinary retention, where you might need to put an SVC, and rarely death. And in this particular outbreak, it's been actually less than 1%. Now, vaccination. So Mpox vaccination is now available in New Zealand through the Mpox consultation clinics. So these are specific clinic, usually run by sexual health clinics or public health units. And the reason why they are specifically being done through these clinics is because of the availability of the vaccine, and the number of vaccines that are available is very limited as of now in New Zealand. And vaccines are thought to be at least 85% efficacious. Now, this is actually Advenios, which is the vaccine that we have in New Zealand, is a third-generation smallpox vaccine, which is effective for prevention of Mpox when given pre-exposure and also early post-exposure. It is a live vaccine, but is unable to replicate, which means the traditional smallpox vaccine caused a scar, and this one can cause a small scar, but not like the smallpox vaccine. The standard dose is 0.5 ml subcutaneously, but what we're doing in New Zealand for the vast majority is to use 0.1 ml intradermally, which it achieves a similar antibody levels and seroconversion rate. And this is a dose-sparing way to make the vaccine go for more people. So however, intradermal cannot be used in those who are immunocompromised, those who have a severe keloid or under 18 years old. And the side effects are very low. So experience from Australia say that only 3% of people needed to take time off work to manage the side effects. The majority will have local reaction, especially after intradermal vaccination, and there might be a small mark on the skin for up to 6 months or longer after the vaccination. Now, indications for pre-exposure vaccination would be those who identify as gay, bisexual, or other men who have sex with men who are at risk of acquiring Mpox. So these would be those individuals who also would meet criteria for HIV PrEP, regardless of their HIV status. And healthcare, as is another group as well in New Zealand, that is if a healthcare practitioner recommends that vaccination would be useful for that person, they could also be vaccinated. And then the laboratory personnel who culture Mpox if their employers think that is needed. Now, post-exposure vaccination for those who have had close contacts with Mpox, including household contacts and sexual contacts, and if given within 4 days, it can prevent an infection. It can be used between 4 to 14 days as well, post-exposure, which would lead to possibly milder illness. And obviously, post-exposure vaccination is also offered after occupational exposure through breach in PPE. So if you have someone who you think might be at risk of Mpox, then the best place to point them to is the Burnett Foundation. This is the old New Zealand AIDS Foundation. It's now called the Burnett Foundation Aotearoa. And they have a risk assessment tool that they can do. And at the end of it, it has a number to contact to book an appointment through Mpox vaccination clinic, because the vaccine is under Section 29 and has to be prescribed by a health practitioner, a medical professional. So in conclusion, we have low cases of Mpox in New Zealand. The rash from Mpox can be atypical and differential can be wide. Men who have sex with men at risk are the main risk group, and health pathways actually has been updated regularly to have all this information. So I would direct, if you have a suspected case, then I would say follow your health pathways. And remember that for the vast majority, management is mainly supportive. And if you have eligible individuals, then signpost them to the Mpox consultation clinics, to the Burnett Foundation website, or to the Healthline number, which is again present in the health pathways. So if you need further information, there's a good review article that was published just last Friday.
Thanks, Teena. Just a quick question from me.
Yeah.
Can you get monkeypox twice if you haven't been vaccinated? Like, is it, are the antibodies protective?
We don't know how, we don't know how long natural or vaccine-induced immunity lasts for, but we definitely know that there have been reports of cases of Mpox in people who have been previously vaccinated for smallpox, like in the US military and stuff, people are offered smallpox vaccination, and there have been cases reported in those groups. So I think the current recommendation, so if your smallpox vaccine was over 5 years, then you could have a dose of another dose.
Great. Anthony, did you have a question there? Your hand
Oh,
up?
I was going to just add in, it's pretty rare for people who have had Mpox or had the vaccination to get a second infection over the sort of first 2-year period in the immunocompetent person. So we feel pretty comfortable. I wonder if chuck Nikki in the deep end since she's just arrived.
Well,
I'm in the deep end. I just ran all the way from the plane. I agree. It's extremely unlikely. So I'm on your side.
yeah, well, lovely to see you here, Nikki, and thank you for jumping off a plane and running for an educational opportunity. So Nikki Turner is the honorary professor in our Department of General Practice and Primary Healthcare and head of the IMAC unit, which is actually based in the Department of General Practice and Primary Care on the same floor anyway. And also she's going to be joined by Kellie Rogers, who's the implement lead for National Hawara Coalition, and she'll be talking about the best care immunization tool. Okay, so over to you two.
Kia ora, Bruce. Thanks very much. And I'll just go for the screen share. So look, I've just got a brief 20 minutes with a bit of support from Kellie, and I'm going to cover quite a few things. So I'll go quite fast and really leave these slides. And if any people have got questions at the end of them, let's discuss. I think the one that people really need to think about is the introduction of the meningococcal B, Bexsero. So if you go to sleep, can you wake up when we get to that one, Tara? So just starting, I think we're all very aware of this. We all know there's been a whole lot of COVID consequences, but one in particular internationally is the drop-off in vaccination rates through not all countries, but through many, many countries in the world. And of course, as we all know, drop-off in vaccination rates is a big problem. And it's not just internationally. New Zealand, we took a bit of a backslide from about 2018 anyway. I think we were struggling a little bit. So we had a bit of a dive, but since 2018, you can see that our vaccination rates have dropped from well over 90% down to 85% at the age of 2, with a much sharper drop, particularly for Māori. So that's coverage at the age of 2. But the other important measure is coverage at the age of 6 months. So this is getting your infants in 1 month after the 5-month event. So that's a very tight measure. And that's really a measure of getting kids in on time. And what we can see from the 6-month drop-off is there's been quite a precipitous drop-off in recent times. And that's a whole lot around how we're struggling with the post-COVID environment. And you can see there's been this really big drop-off, and like it's gone from nearly 90% down to 63%, and particularly for Māori, around 44%. Now, the problem with timeliness of delivery is you don't get the early protection. And so it's particularly pertussis that we'd worry about for not getting early protection. So I think both of these markers are important. So what are we worried about? Well, the 3 I just wanted to briefly highlight was measles, polio, and whooping cough. Look, I think we're all very aware of the issue for measles. I have a nice, simple GP rule in my head. Everyone needs 2 doses of MMR from the age of 1 year, now up to about the age of 55. So if we've got any patients at all under the age of 55 who haven't got a clear 2 records of MMR, don't go hunting for them, just offer them the revaccination. There's no concerns about giving people too many MMR. It's much easier, I think, if we can't immediately find records to offer people revaccination. So that's my strong message with MMR. We vaccinate, we vaccinate, we vaccinate, we don't see measles. So nice, simple rule. You guys would have heard that Te Whatu Ora is concerned about the potential resurgence of polio. This is what we've been seeing internationally. People will have heard that it's they've had a case in New York, they've had it in the sewage system in London, they've seen a case in Israel and Indonesia, places that have not seen polio for a very long time. Very simple rule with polio: vaccinate, vaccinate, vaccinate. So once again, people without records, make sure they're vaccinated. And in the case of polio, particularly if people are traveling. So nice and simple rule, vaccinate. It's pretty straightforward. The one I wanted to really highlight is whooping cough, pertussis. I think with our dropping timeliness of delivery, we're going to see a resurgence in pertussis. So pertussis epidemics come regularly every 4 to 6 years. We're about to see the next one. Just in case we haven't got enough infectious diseases at the moment, we are expecting soon, I can't predict when, to see the next pertussis. Now, with pertussis, you don't get lifelong immunity. Your immunity drops, but it's the kids, the little ones, who are at highest risk. So protection for kids is what it's all about. And maternal vaccination, anybody who's got that double line on a blue stick, please can we make sure we've got them coded in our GP records to chase them up for pertussis and flu vaccination and pregnancy, and then on-time infant vaccination. So those are the 3 simple messages. I think for us, they're really straightforward. The implementation of them and how we find our lost kids and our lost adults is a lot harder. So I'm just going to very briefly pass over to Kellie to make some comments about this great tool that they've got.
Kia ora koutou. Thanks, Nikki. So yes, just one quick slide from me. So with the low immunisation coverage of childhood IMS, what you may see coming your way are children that are overdue and that need a catch-up schedule planned. So in response to this, the National Hawara Coalition has created the Best Care Immunisation catch-up tool with some really valuable input from IMEC, so thank you for that. And it is to support clinicians to give the right immunisation at the right time. So here you can see a snip of the tool. On the left-hand side there, you can see a list of antigens. The next column shows you the current number of doses that have been given and the total number of doses in the next column as required per the immunisation schedule. Anything in green is a vaccine that has been given. Anything in red text is a vaccine that's overdue and it's telling you to give it today. And then anything in the black text is a future date, categorized either as a catch-up or on schedule. As you look below, you'll see that there are a list of vaccines. So that's grouping the antigens together into a vaccine, telling you what you need to go and get from the fridge on that day and then on future days. And you can simply push the add immunisation catch-up recall and it will set the recall within the PMS. The third amazing function on this is the audit tool that audits the enrolled population, and that will look at all enrolled tamariki aged 3 months to 9 years showing overdue for their childhood IMS. It will also be, you'll also be able to filter it by priority patients. And then you'll be able to export it and have a look at the address as well if you're doing an outreach IMS drive. And as of tomorrow, what you'll see is the next version being released, and that will show the MMR status of all patients aged between 10 to 34 years old, and that will be available to search and audit within the PMS as well. So this form is available in MedTech 32, Evolution, My Practice, soon to be Indice. It is free, and we encourage you all to take it up. It needs to be installed. So if this is something that you would like, feel free to contact me, kellie@nhc.maori.nz, or check out the Gen 2040 website, and what you'll see is some contact details there. And please spread the word about the availability of the tool. Cool. Thanks, Nikki.
Kia ora, Kellie, thanks very much. And as an indice practice, I want to be first in line as soon as it gets to indices. So thanks so much. I think it's a fantastic tool. And anything that's going to help us systematise our approach now for our catch-ups, brilliant. So look, moving on, I just wanted to highlight that there's a few resources coming out of Te Whatu Order now. And just here's a few posters. You know, there's been a real focus on 18 to 33-year-olds as a particular group in our population that may have missed out on the MMRs. They're also the particular group in the population that don't tend to think that they are in urgent need of a vaccine, so they're always the hardest to find. And of course, looking at the infant program and the young children who may have missed out. Now, I was going to briefly move on. I've been asked to give a really quick overview of measles. Now, many of us will have remembered measles from 2019 outbreak. So it's a little unfortunate that we just need to clinically refresh ourselves again as to what we're looking out for. Now, to me, as a pretty simple GP in infectious diseases, kids with measles look sick. They have red eyes, they have that blotchy rash, they look miserable. And so I think it's usually pretty easily identifiable. And of course, many of them have those Koplik spots on the inside of their cheeks and their mouths. So we'll all remember that measles cheerfully is even more highly infectious than Omicron COVID. So it's nice to have something beating COVID for a change, maybe not in the best of ways. There's a prodrome that looks really a bit like a cold, that they get a fever, but then they get the conjunctivitis, which I think is really important to be aware of. Lots of the coryza and the Koplik spots on the buccal mucosa. The rash comes out somewhere from day 3 onwards, and most kids are pretty unwell by that time. We all know that complications are really common, and we learnt our lesson from the 2019 outbreak, where about 30% ended up in hospital. We still know that a lot of kids can end up with encephalitis. And of course, the rare severe effects 7 to 10 years later of the degenerative SSPE. I think New Zealand did incredibly well with its secondary tertiary care in 2019. We didn't actually get any deaths, but we had about 10 cases in ICU. And just to remind us, these are the people particularly affected by measles. This is from the 2019 outbreak. We're likely to see the same pattern if it comes back. We'll see measles in the little kids, and in that sort of teenager, young adult, midlife adult, where we've still got gaps in immunity across our population, and many people who are unaware. Now, in terms of what we do about it, I think the Auckland Regional Clinical Pathway has recently been updated, and I think it's very nice. It essentially says, if you see something that looks like measles, take a nasopharyngeal or a throat swab, particularly within 7 days of the onset of the rash. If you see somebody after that time, still have a go at a swab for a PCR, but also take a urine sample if they present a bit later. And I think something new for me is if you see somebody more than 21 days after the rash, still consider taking a urine sample, and they can look for measles virus RNA in it. So that's something worth remembering if we see any delayed presentations. I think the one thing to remember for all of us is there's really no point in serology these days. It's really about getting a PCR swab. So that's a very brief update. We've all got that available on the clinical pathways to remind ourselves. So I'm going to shift from measles just because we're so excited by a lot of infectious diseases these days. Flu. So we are gearing up for flu vaccination program. The information should be coming out on the flu vaccination program by the middle of March. We should be able to order vaccine and start delivering it by the 1st of April. It's at this stage, it's pretty straightforward. At this stage, Pharmac is telling us that the high-risk groups are as previous, which is 65 years and older, younger people with significant medical problems as previously. As yet, we haven't heard if there's any extension of groups elsewhere. We're all aware that last year we focused on 55 to 65-year-old Māori and Pacifica as well. That has not been announced at this stage. We don't know. We're also keen to try and vaccinate more young children. But at this stage, from Pharmac, it is just those with high-risk medical conditions. The 2 vaccine brands at the top are the current ones we use, the standard quadrivalent traditional vaccine, which is in this brand is called Afluria Quad and Afluria Quad Junior. Now, like we've had previously, Fluad Quad in that bottom left square there is the adjuvanted vaccine. We did have the privilege of having that for 1 year in 2021, I think, for adults 65 years and older. Because it's got an adjuvant, it drives I could say an elderly immune system, speaking of somebody who's heading that way, it drives the older immune systems to get a more effective response to flu vaccine. So Fluad Quad has got probably some gain over the non-adjuvanted, but it's only available on the private market. So when your patients come and ask, should they be buying it? The answer is, well, it depends. You'll have to pay for it. There are small, modest, but probably real gains over the non-adjuvanted. So I'm just putting up one piece of data to suggest that if people want to consider the adjuvanted and they can afford it, there may be some modest gains, just so we're aware of that. The flu kit should be coming out soon within the next couple of weeks, so more information there. Now, moving again, alongside flu, I would be really, really keen this year for us all in general practice to get into the COVID vaccination game. Hopefully most of us are in there now offering COVID vaccinations. Now, the new arrival on the block is that New Zealand has purchased the COVID bivalent Pfizer vaccine. Now, the difference is we've been using a monovalent up till now, which has got the original Wuhan strain in it. This new bivalent has got half that and half the Omicron 4.5 strain in it. So it's, you know, it's a bit like what people have done with flu vaccines. They've put two different strains together. Is it better than the monovalent? Well, you can't say definitively because they haven't done a head-to-head. However, it's clearly showing good effectiveness and it's looking good. So the data to date shows its immunogenicity response is really good. It has good vaccine effectiveness when used as a booster. So it's definitely as good as the monovalent and probably better. So it's great that we're getting it in New Zealand. And I'd highly recommend it that we can offer it to people who have missed out on their booster vaccination. I'd be very keen as people start rocking in for flu vaccine to ensure that everybody is up to date with their boosters for COVID. Now, of course, everyone's wanting to know if we are going to be offering another booster. We are waiting to hear further announcements from the ministry about if and when we will be offering a further booster. I would hope that we will hear some news and we should be able to consider it alongside flu vaccine. What we'd love in the future is a combination COVID flu vaccine, but unfortunately that's still a year or two away. So at the moment, it's great news that we've got a bivalent available to us, and that will be replacing the monovalent. Now, this is a chart of all the different COVID vaccines that may be sitting in your fridges. The maroon cap, delicate maroon color, is for just the kids under 5, and there's only a few places in the country holding that because this is only very high-risk kids. The orange cap for kids is the 10 microgram. The purple cap was the original one that you had to mix up. Now, the new grey cap, you don't have to mix up. So the purple cap's being removed. And we'll be left with 2 grey caps, confusingly. One's the monovalent and one's the bivalent. Now, if you mix them up, it's probably not the end of the world, but the monovalent is there really for a primary course, for anyone who hasn't yet had a primary course, and everybody else should be switched to the bivalent for boosters. So that's my little summary. Now, the last one I want to get onto is meningococcal, and it's because clearly we don't have enough to do out there at the moment. We're about to introduce Bexsero, the meningococcal B vaccine. So I think we all urgently need to know a little bit about Bexsero and how it's being planned to be introduced. So the intention is to introduce Bexsero on the 1st of March in the infant program. Now that's not far away. So firstly, why are we doing this? Well, this is just the latest graph on the incidence of meningococcal disease in New Zealand. And what you can see is that, you know, we had the hiatus like we did for a lot of infectious diseases for 2020 and 21. And now, as you can see, we've got the rise, particularly of B. And what age groups is it in? It's in our infants and in our mid-teenagers. And you can see once again, proportionately, Māori and Pacifica infants are really getting hammered by this disease. So here's the importance of introducing Bexsero. So this is the latest data from the ESR, just looking at that. So what is Bexsero? Well, just to remind ourselves that meningococcal disease is either A, B, C, W, or Y normally. We have an excellent conjugate vaccine for A, C, W, and Y, but for a whole lot of technical reasons, you can't make B out of a conjugate vaccine. So we've got the conjugate vaccines there on the left that we are using, but as you saw from the epidemiology, we really need a B vaccine. So the B vaccine that New Zealand's purchased on the market is called Bexsero. Bexsero has got 4 different protein components in it. Interestingly, one of the 4 proteins, for those of us who remember the meningococcal B outbreak many years ago, has got the outer membrane vesicle of that New Zealand epidemic strain in it, as well as 3 other components. It's been licensed in Europe and Australia for a while, and it's been used in the UK for quite a while now. So our best data is out of the UK. So reminding ourselves that there is a high-risk group already funded of young people aged between 30 and 25 who are living in environments where they're in crowded conditions and others. Now, they've already been funded for the quadrivalent vaccine. From the beginning of March, they will also be funded for a 2-dose Bexsero. So that's a 2-dose regime that's coming in for those people from March. But the big news for us is the new infant schedule from the 1st of March. Now, we had clinically wanted to start giving this vaccine in the 6-week event because we're seeing so much infant meningococcal disease. However, unfortunately, the legal advice to Te Whatu Order in the Ministry of Health is because the licensure is actually from 8 weeks, we cannot, within licensure, start this vaccine at 6 weeks. So the recommendation that has actually just come out today is that Bexsero will be offered on the routine infant schedule at 3 months and at 5 months, and then a booster at the 12-month event. Now, for those of us, if it's possible, and we see the infants or are able to get them in earlier, you can start from 2 months and 4 months. If you choose to start from 6 weeks, it would be outside of licensure, so it would require a prescription from a medical practitioner. Now, clinically, this vaccine would be fine from 6 weeks, but legally it is not licensed from 6 weeks. So this is what the schedule is going to look like. You can see at 3 months that you'll have a 2-dose regime of the standard Hexa with Bexsero, and at 5 months you'll have a 3-dose Hexa, Prevnar, and Bexsero. Just remembering, if it's potentially possible, you can start earlier. So that's the news for that. Do they work? I'm running out of time, so I'm leaving everybody with a couple of slides to show that they're overall pretty effective. So that first one is efficacy, and the second one is real-world experience from Australia, the UK, Italy, and Canada. So do these vaccines work? Yes, we'll have to see how it works within the New Zealand context. One big important issue for Bexsero, and this is a real challenge for us, is that it is very reactogenic. It works, but it does cause a lot of injection site tenderness, and in particular a fever. Now, because of the problem with increased fever, it is internationally recommended that we give a dose of paracetamol, an antipyretic, when we give the vaccine, and 2 further doses at 6 hours and 12 hours later. Now, this is a real problem for us in service delivery land, but the reason for doing this is that Bexsero really is very pyogenic. It does cause a lot of fever, and if we don't keep the fever down, we end up with a lot of infants being investigated unnecessarily for high fever. So the real message for us is get used to, just for Bexsero, using paracetamol as an antipyretic, just for Bexsero, not for other vaccines and not for other reasons. We're not recommending antipyretics routinely. We're not reading them in general. It's just for Bexsero. So here's the current recommendation used for infants and children under 2. When receiving Bexsero, it'll attenuate the fever and discomfort. You give 3 doses. We're recommending, if the kid's really little, give 2 mils. 4 kilos or up, give 2.5 mils. You give 1 just before or at the vaccination time, and 2 further doses 4 to 6 hours apart. The only other thing I'd like to say is don't give out large amounts of paracetamol to people with little kids, because the overdose concern is that people then take lots of doses. So that's what we're a little worried about. So there's my quick romp through it all. I hope everyone got that and managed to stay awake. And good luck to us all in introducing Bexsero. It's a clearly really important, frightening disease, a very effective vaccine, but there will be a few delivery challenges. I think the other thing I didn't mention is there is intending to be a catch-up program for all children up to the age of 5 to have 2 doses of Bexsero. So there's a lot of work for us all in the immunisation space. And I just want to acknowledge all those that helped me put these together. This is Eric. Eric is very useful when you want to put together PowerPoint presentations in a hurry. So kia ora, and I hope I'm not too far over time.
That's great, Nikki. Thank you very much. Clear and crisp as usual. Our final speaker is Tim Cutfield again, who's going to talk about iGAS. Over to you, Tim.
Oh, thanks, Bruce. This was slightly a surprise to me because I don't profess to be an expert in Group A strep in a country where there are many experts in Group A strep, and I guess it might be good to open up as a bit of a group discussion, because I know there are other people here who will have insights, but I think the reason for this was reflecting on infectious diseases that have been seen in different parts of the world and what we might expect in the months to come in 2023. And many of you will be aware that in the Northern Hemisphere, there's been really quite high rates of streptococcal associated disease, in particular invasive strep pyogenes illness that led to an increase in fatalities where they hadn't seen such levels in many years. And it's probably reflecting what Nikki's just touched on, that there's been a surge of people getting together, spending time together, sharing bugs, be the viruses and their upper respiratory secretions, and mixing and mingling. And some data to suggest that possibly associated with upper respiratory tract infections, the secondary risk of invasive group A strep might be increasing as well. But regardless, I guess for New Zealand's situation, we see a truckload, distressingly high number of streptococcal associated illnesses all the time. And I think probably our primary care setup is such that all of the audience will be familiar with the presentation with many streptococcal infections. And the ones that are really nasty, you know, necrotizing fasciitis, bacteremia, septic shock, you can be sending those people into hospital anyway. The one trick, I guess, which is interesting for the UK strain is that it did see a significant rise in the incidence of scarlet fever. And while we don't have great, at the moment, as far as I'm aware, up-to-date typing of strep pyogenes infections in New Zealand, I saw a lady with, like an adult with scarlet fever last month, which may be a shot across the bow for perhaps some increase in these nasty streptococcal infections in the months to come. But I think the shopping list of things for us to focus on that are preventable that Nikki's given us is long enough. Don't know if anyone else has comments.
So if we, I guess there's one question here. If we're going to be giving the COVID vaccine and the flu vaccine, how long do we have to get people to wait afterwards? Because with the flu vaccine, you can just send them home before.
Yeah, technically not just send them home. With flu vaccine, technically it's meant to be 5 minutes. I just like to remind us all. It takes them 5 minutes to get out the door anyway, most of my patients. COVID is 15 minutes. So if you're giving flu and COVID, it's 15 minutes just to cover the COVID one. Childhood vaccines, 20 minutes. We would like to line them all up ultimately to 15, but we just have to take a while to get that going.
Okay, Nikki, Pamol for infants on PIPA trial, okay to use ibuprofen instead?
It is okay to use ibuprofen instead, yes.
Yep, okay. Okay, so with Bexsero, would it be best to give 2 vaccines in one leg and 1 vaccine in the other?
Yeah, that's the right, and that's what we're going to suggest. And because Bexsero is the more reactogenic, you'd put that in its own leg and put the other 2 in the other. Vaccinators, bless them, have done this in the past. I can't believe how amazing they are, and they do see once you get used to it, it's okay. I think it's the toddlers that are much harder. At least the infants are a little more compliant.
Our nurses get 2 nurses and they give it at the same time, which is amazing.
Yeah, no, a lot of practices don't like that, Bruce, actually. They say it's just surprises the kids and the parents. But, you know, whatever works that people and practices are comfortable with.
Yep. Why aren't all members of high-risk households targeted for flu vaccine coverage? I don't know who wants to answer that, maybe Nikki?
Totally agree. Why aren't they? We are disappointed with the narrow funding for the flu vaccine this year. Personally, I think it just should be offered universally, but we certainly wanted it to be offered to all kids, all little kids, because they've got the burden of flu, and also to lower the age, particularly for Māori and Pacific. So at this stage, that's an answer for Pharmac and the Ministry of Health working with Pharmac.
Okay, so, okay, we've got that, yeah, okay. For infants who are already 3-month-old of March the 1st, what is the dosing schedule for Bexsero?
Yeah, so we'll be passing it out. So it's essentially a catch-up process. So depending on the age, it will be in the handbook soon, and it will come out in the information how you do a catch-up. Essentially for under 1s, it's 2 dose, 1 year's enough, plus a booster. And for the older kids, it's just 2 dose.
Okay, what about the effect of paracetamol on pneumococcal vaccine? Won't the prophylactic dose not interfere with Prevnar vaccine? I don't quite.
Yeah, that's right. So there was an early concern that it does blunt the immunogenicity. However, Prevnar, particularly Prevnar 13 is a very responsive vaccine. It's a conjugate. So even if you get slight blunting of the immune response, it doesn't affect its effectiveness, its efficacy. So it's okay to use it with Prevnar. You know, we have to say, you know, it's tough having to use Pamol, but it's much safer, I think, than having lots of kids with pyrexia that need working up. And our pediatric colleagues will be very grateful if we don't start sending lots of fevers into Starship and pediatric wards.
It's interesting, the reduction in otitis media, which people think is due to those vaccines. I now have trouble showing the 50-year medical students what acute otitis media looks like. I used to always be able to do it 10 years ago. Now I feel really excited if I see one, and it's very rare. It's amazing, really. Okay, so who's eligible for the new COVID booster, and what is the spacing from last dose?
Yeah, so the bivalent is just going to swap out the monovalent. So everybody for a booster who's available for COVID vaccine now, they'll just get the bivalent instead of the monovalent. So it's just what we're waiting to hear from the decision from the Ministry of Health is future boosters. Our general clinical advice now is a booster should be 6 months after the previous one. There has been previous advice about 3 months as a minimum, but generally, I personally would recommend 6 months, unless there was some urgent reason to make it shorter.
Okay, we're just about out of questions. So I just wonder whether the panel would like to, got any final words they'd like to say, any burning comments that, there's a question there about Bexsero, I think, Nikki.
Sorry, I'll give that last one, Bruce. It's just
Yep.
Mum's concerned about amount of vaccines at a single event. That is about the confidence and the knowledge of a vaccinator. That we are confident about our science here, that these are good new vaccines. We're not chucking in lots and lots more antigens. It's really about how we confidently work with parents. And there's a lot of evidence there that if the vaccinator is confident with their immunisation event, the amount of vaccines is not the issue.
Okay, so anybody got final words there? Anthony, you want to got a final word?
I've got some pictures of the Mpox intradermal vaccination that I've shared with IMAC, and we're going to put it up on the website. But I maybe just want to show the group what it looks like, just because it is something that develops over time, and they may turn up at the clinic and say, "What have you done to me? Is this normal?" So I might share that on the screen.
Okay, that'd be good. Yeah, yeah. So is
this,
that raised, Anthony, or is
yeah? So this is, if you think about like a BCG or something like that, that will form a little bleb on the skin. And this is what it looks like just after we've injected it. There are 3 locations that we offer people for scapula, upper arm. But this is what it looks like to start with. Then the next day it goes away. But subsequent days, it turns up red. So this is just to reassure patients and clinicians that it is normal for it to develop like tuberculin skin testing or other types of reactions days, and it can actually outlast months in some people, especially people with darker pigment skin. So I always talk about people like of my skin color, that it's not uncommon to get a little bit of pigment there left afterwards, but it's nothing to be concerned about. So this is what the development of an Mpox site looks like. In some people, it may form a central sort of area like this last one here. It sort of fades down, and it may even, in some people, form a little punctum or scab at the site. But again, those are all normal responses and nothing to be concerned about.
Just got a question from Michael Miller, GAS positive patient, late teens, 20s, low risk traumatic fever. Should we give antibiotics? So presumably a throat swab's being taken.
I mean, my instinctive reaction would be that at the moment, we don't have any evidence that anyone should be doing anything differently with strep pyogenes assessments in New Zealand. I guess it's plausible that if we thought we had a really nasty strain doing a whole heap of badness, that, you know, advice might change, but that's not the case at the moment, as far as I'm aware. Bruce, can I ask Anthony a question?
Yes,
it's okay.
go for it.
I'm worried about, and I think a number of us are worried about measles and the effects it's going to have on our patients and our quality of life when it inevitably does come. Anthony, do you have any tips or thoughts about the practical processes of navigating close contacts who are exposed and maybe vulnerable?
Yeah, so there is advice around ring vaccination and times for contacts. There are also advice around, the Starship's website's quite good around using in certain populations NIG or normal human immunoglobulin against measles, and in older pregnant, I shouldn't say older, in pregnant people about using IVIG just based on a weight-based. You can't really use IM immunoglobulin. So we're focused on getting that process clear, updated on the website. Actually, the science around it has been there for a long time, but the process to get that delivered has been the tricky bit that we're working on locally across the Auckland Metro region and sharing with our colleagues across the country.
So I'd just like to thank you all. I think it's been a great evening. So, so thank you very much, and over and out from us.